Well, thank you so much. We're so very honored to be invited here to talk today about some of the research we've been doing around racial disparities in COVID-19 mortality. And so thank you so much for that kind introduction. A few disclosures. So content on racial disparities was adapted from a COVID-19 course that I developed with one of my colleagues, Dr. Manasa Ayala, here at Rutgers, New Jersey Medical School. And we're going to be presenting our research, which was really the product of a wonderful collaboration between faculty at the School of Public Health, faculty and students at Rutgers, New Jersey Medical School, and also at Rutgers Robert Wood Johnson Medical School. So it's wonderful to see that the collaboration between schools and also between faculty and students to put together this really critically important research that we're pursuing in understanding what drives disparities, particularly related to COVID-19. And we have no relevant financial disclosures. So these are our learning objectives for today. The first is to define some key terms that help us really kind of understand what's happening with racial disparities. So we're going to define race, racism, social determinants of health, anti-racism, and health equity. We're also going to identify how structural racism shapes health disparities for racial ethnic minorities and describe how racial disparities in COVID-19 mortality are associated with social determinants of health, which was the subject of our study. And lastly, we're going to outline some public health policy and approaches that can mitigate COVID-19 racial disparities going forward and other disparities. So it's important to recognize that when we're talking about racial disparities, what we're really talking about is racism. And racism is a public health issue. And I think that we have seen a racial reckoning across the nation over the past year as COVID-19 really magnified and really unveiled for us the stark inequality that exists in our country. And this was a quote that kind of went viral on Twitter and other areas that I had a hard time really tracking down the source for it, but nothing can go back to normal after we recover from this. Normal wasn't working. And if we go back to the way things were before this racial reckoning, we will have lost the lesson. May we rise up and do better next time and going forward. And you know, the national associations of the American Medical Association and National Associations for Public Health have really declared racism as a public health issue because of the massive amounts of data that show us that racism has a profound effect on health. And usually that's through the social determinants of health. So just to get us all on the same page, when we're talking about race and racism. Race is the classification of humans into groups that are based on physical traits, ancestry, and social relationships, or the relationships between them. So it's a social construction and creates social groupings, these made up demarcations that have changed over time and vary around the world. And it's a crude proxy for things like socioeconomic status and culture and genetics, but it's a very precise measurement of a social classification of people in a race-conscious society, and specifically a society that has based value based on a hierarchy of human value. Racism is a system of structuring opportunity and assigning value based on the social interpretation of race. And this means that racism unfairly disadvantages some based on their racial grouping and unfairly advantages others. This is what Isabel Wilkerson in her famous book, Caste, describes as a caste system of hierarchy of human value. And importantly, Camara Jones, who is a family physician, she worked for the CDC, and she also is a race scholar. What she points out is that racism saps the strength of the whole society through the waste of human resources, and that's very important to recognize. Social determinants of health are the structural determinants and conditions in which people are born, live, work, age, and which profoundly influence health status. And importantly, we have to recognize that these circumstances aren't just happenstance. It just doesn't happen this way naturally. It is shaped by the distribution of money, power, and resources. And these fall into multiple different buckets. And this is defined by the WHO and the CDC: healthcare access and quality, education, economic stability, neighborhood conditions, and the social context. And all of these have been well defined in the literature as having a profound influence on health. And when we think about the different levels of racism, they all interact with one another, and they work together to kind of maintain this caste system within the United States, where we have interpersonal racism, internalized, institutional, and structural. But of course, they all work together and they're all interrelated. And they all have different effects on health. And where we're going to be concentrating today is really on the structural components, because the structural racism that exists in the United States can lead to health disparities related to the social determinants of health. And of course, that's what we explored in our study and what we're going to be talking about today. And so when we look specifically about COVID racial disparities, there's this wonderful website that the CDC has that's referenced here at the bottom of the slide that has a lot of interactive components to it, where you can explore disparities related to the incidence of COVID-19, the incidence of severe disease and hospitalization, and of course, racial disparities related to mortality. And this is the most recent data that they have up on this website just from a few days ago, where I have here looking both at United States level data and New Jersey level data related to disparities in COVID-related mortality. And if you look at this graph here, this is comparing for each group, the bars represent the difference between the percent of COVID-19 deaths and the percent that this group represents in the overall US population. And so bars above 0 suggest that a given racial or ethnic group is experiencing a disproportionately high percent of COVID deaths relative to their percent in the population. And so the higher the bar, the larger the disparity, like here you see for this group, ethnic group of Hispanic. Bars near 0 suggest that there's very little disparity, and bars below 0, like here for the group identified here as white, we have a bar far below 0. This means that the relative burden of mortality is less than the representation of this racial group in the US population or in the New Jersey population. And you can see in comparing the US and New Jersey that the graphs look very similar, and that we see a high burden of mortality among those who identify as Hispanic or Latinx, and as well those who identify as Black, as well as disparities related to American Indian, Alaska Native. And you can see that there's protective effect of white race against COVID mortality when you look at this data. And New Jersey looks very similar. So there are very well-defined disparities that we can see across the board when we look at disparities for COVID. And what drives this? We're kind of putting together social determinants in COVID. We can think of multiple different factors that increase a person's risk of either acquiring COVID or having worse outcomes related to COVID. And so many of these are really shaped by structural racism and discrimination. For example, housing discrimination and segregation can lead to populations of color disproportionately living in areas with high levels of toxic pollution, or high levels of high density or multi-generational housing. Discrimination also leads to less wealth and socioeconomic factors, where people might be more likely to have essential jobs or to be unemployed. Healthcare access, of course, plays a major role in this as well. Food insecurity can lead to a higher burden of chronic illnesses, which we know are associated with more severe COVID manifestations. And of course, education and exposure to chronic toxic stress leads to an actual physiologic response that can increase the number of comorbidities that someone may have and stigmatize and further marginalized populations. So all of these kind of work in concert to put certain groups at higher risk of outcomes, higher risk outcomes for COVID-19. And this was a really interesting recent study, and you can actually go to this website as well and explore, again, interactive maps based on where you live in New Jersey or where you live in the United States. And what they've done here is they've compared and overlaid redlining maps with CDC social vulnerability scores. So redlining was the practice by banks in the 1930s and beyond of using maps to block areas deemed to be of high financial risk. And these were typically in neighborhoods of color, Black and Latinx neighborhoods in particular. And this would limit the access to loans, mortgages, and insurance. And as a result, banks and other mortgage leaders rejected loans for creditworthy borrowers based strictly on race, low income, or geography. And the US government once supported this practice as a better lending practice. But ultimately, it led to generational wealth gaps that are severe and very well documented for communities of color in the United States. And what this study did is it compared these maps to what we call the CDC social vulnerability score. So again, social vulnerability, meaning the social determinants of health that lead to a greater risk for comorbidities, such as hypertension, diabetes, obesity, all factors that have been associated with a higher risk for poor outcomes related to COVID-19. And then if we think about this as a continuum, across the continuum of COVID incidence and care and outcomes, we see that there are racial disparities across the board. And these have been very well documented, not only in the medical and public health literature, but by the media throughout this pandemic. So first starting with the inability to physically distance or having an essential job where you need to be out in the community doing your work and exposed to COVID doing that work. Limited access to testing in communities of color. Limited ability to isolate or quarantine, either because of work restrictions or because your home is simply not set up to facilitate that because you lived in a shared living space. A higher prevalence of chronic illness, which we talked about before, related to the CDC social vulnerability. Disproportionate impact of mitigation efforts. For example, if you were disproportionately affected socioeconomically because you are unable to work or because your workplace has been shut down and now you are at risk of eviction or having your electricity or water shut off, this also disproportionately can affect your risk for COVID and risk for poor outcomes related to COVID. Lower access to quality care because you live in an area where the medical infrastructure has been neglected, or lower representation in clinical trials, which is very well documented among trials for both treatment and vaccines for COVID. And lastly, now that is being well documented, is that there's lower access to vaccines as well across the United States for populations of color. So all this across this entire continuum, there are really incredible opportunities for us to do better because it's now very well documented that disparities exist across the entire continuum. But really, how did we get here? And I'm not going to go into too much detail in talking about this, but this picture here is a picture of our parking lot at the medical school. And a year ago, this is what it looked like. It was a makeshift morgue with refrigerator trucks throughout the entire half of the parking lot. And I would pass this every single day as I came into work to care for COVID patients here at the hospital. We were completely overwhelmed at University Hospital with the influx of patients that we treated and saw so many people tragically pass away in the context of this last April and May and June in particular. And I had to kind of think of myself, like, what are the things that I have seen throughout my career that I notice have been really important factors that have gotten us to the point where we have not been able to really respond to the pandemic in a way that would have saved more lives. And there are lots of different issues here. The criminal justice system, which has led to mass incarceration. And at the time of when we had the most admissions to our hospital, we had admissions from all over the state of incarcerated individuals who really had no protection from the COVID pandemic ravaging through prison populations. There's been a devaluing of primary care, and I provide primary care through the clinical care that I give. And there's also a devaluing of community-based care. We know that this is reimbursed at a much lower rate and really not valued as much as high specialty care in the United States. There's been an incredible lack of investment to study and research social determinants of health and health systems and how they deliver care and how they might do that better. There's been a lack of investment in occupational health, which led to a lack of protection of workers in the context of the pandemic. As you all know, coming from public health backgrounds, there have been massive budget cuts across the country related to public health systems. And then, as we know, working at University Hospital here in Newark, the only public hospital in the state, there are underfunding for our clinics and our hospitals. There are Medicaid reimbursement shortfalls that put us at greater risk and for financial fragility, and also means that we have less money to reinvest into quality care programs. And of course, there are multiple policies that also enhance disease stigma and actually really sort of reinforce racism and structural racism throughout our legal and policy climate around healthcare and public health as well. So at the time that we proposed, the students came to me proposing that we do this study, there was actually a lot of evidence coming out, especially in the media, about this drastic disparity among Black Americans and Black communities that were being disproportionately affected. And this is just one news report from Mother Jones magazine, where they demonstrated here in multiple states where the information was available and the data were available, that Black communities were being highly disproportionately affected. So here, for example, in Michigan, Black residents make up 14% of the population, and yet Black fatalities made up 43% of the deaths in Michigan. And so the students really came to me wanting to explore this a little bit further and look at some publicly available data that could help us really understand what was driving this. Because at the time, there were small studies coming out in major medical journals that were suggesting that maybe there was some biological determinant for this, or some genetic variant that could explain why there were these differences noted. But of course, an understanding that racial disparities are far more likely and far more strongly associated with racism and discriminatory policies, we wanted to look at instead at social determinants of health. So I'm going to pass it on to Matthew, my colleague, to kind of talk about the study that they designed and went forward with.
Yeah, thank you so much, Dr. Della Piazza. That was a wonderful kind of overview of the landscape of social determinants of health, and then sort of some specifics about how they could contribute to COVID disparities in mortality. So I'm going to pivot, as she mentioned, to sort of the specifics a little bit of the study we did and why we did it and what we found. As Dr. Della Piazza already mentioned, it was early in the pandemic, and it was yet already becoming very clear that there were racial disparities in COVID-19 mortality, particularly for Black Americans. And as she mentioned, there were sort of competing ideas about what was kind of driving that issue. On the one hand, there was the thought of sort of like hypothetical biological causes that we did not think were nearly as likely or as important to be driving this, but rather consistent with other historical health inequities. Social determinants of health were, we thought, likely to be a driving force causing these or contributing to these racial disparities. And although this was not necessarily, a unique idea, there were already viewpoints in journals kind of coming out suggesting that social determinants were likely involved and should be explored. We did not yet see any formal quantitative analyses of this topic. So with that in mind, we wanted to do a quantitative analysis of racial disparities in COVID-19 mortality and the association with social determinants of health. We did that by looking at publicly available COVID mortality data from the county level from January 22nd, 2020 through October 28th, 2020. And the mortality data came from a Johns Hopkins database that had mortality data and cases for all counties in the US. And we also got publicly available county level data on social determinants of health from the county health rankings, and the Vera Institute of Justice. So with our analysis, we had mortality data available from 2,831 US counties. We decided to only analyze counties that had 5 or more COVID deaths at the time, at the end of our study. And then we also limited our analysis to counties that had complete data on everything in the study, including covariates, racial demographics, and social determinants of health. So that left us with 2,026 counties from all 50 states. So as Dr. Della Piazza mentioned when she kind of defined social determinants of health, it's this really complex, broad term that encompasses really anything that can affect a person's health. And so in thinking about this, we were given kind of an infinite number of possibilities of what we could explore as a measure of social determinants of health in this study. So what we tried to do was think based on kind of our own theoretical framework, as well as representation in literature and what was available to us in our databases, to come up with kind of a broad, diverse array of social determinants of health variables that sort of extended across multiple categories. So for socioeconomic measures of social determinants of health, we use something called the Index of Concentration at the Extreme, or ICE income. Essentially, this is a measure of economic privilege that measures the difference between the number of households in a county living above the 80th percentile income versus the number of households in a county living below the 20th percentile income. And this is a measure that has been linked to disparities in health outcomes in literature. We also considered insurance status with the percentage of uninsured adults in a county. This was important because insurance status, we felt, could mediate access to healthcare as well as ability to pay for healthcare during the pandemic. Then regarding health status, we chose to work with the percentage of low birth weight births in a county. This is important first because it's a measure of sort of general healthcare access and then, prenatal care access. But it's also important because historically, maternal and neonatal outcomes have been linked very strongly with racial disparities in the United States. Regarding education, we focused on the percentage of adults without a high school diploma in a county. So this was sort of a twofold reasoning. On the one hand, education status may have affected a person's ability to kind of digest and synthesize COVID-19 guidelines and act in a way that would be most easily compliant and safe regarding these new guidelines. But also, education likely is related to a person's ability to work from home, such that those with higher levels of education were more likely to be in jobs where they could stay at home and work from a computer rather than working as an essential worker in an in-person environment and getting exposure to COVID that way. Then for sociodemographics, we considered the incarceration rate. As Dr. Della Piazza already mentioned, this is relevant in the pandemic, first because there was a huge problem with COVID-19 spread among incarcerated populations that were given very little protection, but also incarceration rate is a really strong example of a racial disparity in the United States, given the massive difference in lifetime risk of incarceration depending on one's race. And then finally, for the percentage of households without internet, we considered this as an important social determinant of health because a lot of timely information about COVID-19 guidelines and updates really required internet access to be able to easily access and read these materials. And so we felt that would be important to consider in the study as well. So we also included covariates in our analysis. Essentially, these are some factors like the percentage of the county that was above 65 years old, or the percentage of county with cardiovascular risk factors or diabetes, factors that had already kind of been described as being risk factors for COVID-19, serious infection and death. And while these were not exactly what our focus was, we were focusing on social determinants of health, it was important to include these factors in the model so that we could study the effects of social determinants of health on racial disparities in COVID-19 mortality, while holding these important covariates constant. So for our statistical analysis, first we did a t-test, which basically compared the average level of the percentage of Black residents and social determinant of health levels in counties that were in the highest group of COVID-19 death rates, and compared it to those same levels in the counties with the lowest levels of COVID-19 death rates. We also did 3 negative binomial regressions, and we'll talk individually about what was incorporated in each of those models. But in each regression, the outcome or dependent variable was the total number of COVID-19 deaths in the county, and population was used as an offset variable. And so the 3 models we will discuss are the individual social determinants model, the full social determinant model, and the subgroup and interaction model. So on the left of the screen is model 1, the individual social determinants model. What you'll notice is the independent variables included include those covariates we were just discussing. And they also include either one social determinant of health indicator of the 6 we discussed, or the percentage of Black residents. So essentially this was 7 individual regression models. And the chief question we were asking here was, independent of these covariates, is there an association between the percentage of Black residents and then each of the social determinants of health indicators and COVID-19 mortality? Then moving into model 2, the full social determinant model, again, you'll notice the same covariates are included, but this time we've included the percentage of Black residents and all 6 of the social determinants of health indicators. And so in doing this, we were kind of asking 2 key questions. One was, is the percentage of Black residents associated with COVID-19 mortality independent now, not just of the covariates, but also independent of social determinants of health? And then the second question was, are there any social determinants of health that sort of stand out as particularly important drivers in the context of COVID-19 pandemic? Finally, for model 3, this was the subgroup interaction model. So essentially what we did here was kind of the same as model 1, the individual social determinants model, where we included all the covariates and then the percentage of Black residents. But what's different about this model is we sort of split it in half, where we had a regression with half the counties that we called our low adverse social determinant group, and half the counties in the high adverse social determinant group. So I recognize that it can get a little confusing with directionality, because low adverse social determinant counties would be places with like a high income. So I just want to give an example of with like our data to sort of further elucidate what we did here. We can talk about the percentage of low birth weight. So we took the 1,013 counties with the lowest percentage of low birth weight births, and we grouped them into the low adverse social determinant of health group. And then we took 1,013 counties with the highest percentage of low birth weight births and included them in the high adverse social determinant subgroup. And then we did a regression where we focused on the percentage of Black residents and its association with COVID-19 mortality separately in these 2 groups. And so the question being asked here was, is the relationship between the percentage of Black residents and COVID-19 mortality different based on the levels of adverse social determinants of health? And then finally, our last model was an interaction model, which we'll talk about a little bit later. Essentially, it's investigating the same concept as the subgroup analysis. It's kind of just a more formal statistical method to assess this. So now we're getting into the results first of the t-tests. What you'll notice is in the counties with the highest quartile of death rates. On average, there was a greater percentage of Black residents at 22.7% compared to 5% for counties in the lowest quartile of death rates. Similarly, across all of the measures of social determinants of health, you'd notice that for counties in the highest quartile of death rates, there were higher levels of adverse social determinants of health. It's worth noting, though, that this test is just measuring kind of the raw averages for each of these things, but is not taking into account the covariates like the regression model does. So this is the first regression result for the individual social determinant model. What you'll see is that as you increase the percentage of Black residents in a county, there is an increase in COVID-19 death rates. Similarly, as you increase the level of adverse social determinants of health for all 6 of our social determinant of health measures, there is an increase in COVID-19 death rates. Now, if you recall, for the full social determinant model, our 2 key questions were, first, does the percentage of Black residents, is it associated with increased COVID-19 death independent of social determinants of health? And the result, according to this model, is no. The reason for that is, now that the social determinants of health are included in the model, you notice that the percentage of Black residents as compared to the prior analysis is no longer a statistically significant positive predictor of COVID-19 mortality. Then the second component of our key questions here was, were there any social determinants of health that kind of stood out as particularly important? And you'll notice that the percentage of adults without high school diploma and the percentage of households without internet access both kind of stood out as continuing to be associated with COVID-19 mortality, even when we included other social determinants in the model. Finally, this is the result for this subgroup analysis. So these results that you see for the incidence rate ratios represent the ratio for the percentage of Black residents in each model. And you'll see that on the column on the left is the low adverse social determinants subgroup. And basically what we see is that except for the percentage of uninsured adults, across the other 5 social determinant of health indicators, the percentage of Black residents is not associated with COVID-19 mortality in this low adverse social determinant subgroup. In comparison, for the high adverse social determinant subgroup, you'll notice that the percentage of Black residents is associated with increased COVID-19 mortality for each of those 6 indicators of social determinants of health. Finally, these are the results for the interaction model. So essentially, the sort of short summary of this is that there were no statistically significant results in this analysis. And I think it's important to kind of consider why these analyses are done as compared to subgroup analysis. So essentially, an issue sometimes with subgroup analysis is if you're always testing usually at a p-value of 0.05, which means you're sort of comfortable with a 5% chance that these findings could be due to random sort of error rather than the relationship you're testing. But if you do a lot of subgroup analyses, now you're kind of increasing your odds for getting that sort of result because you're sort of just rolling the dice a bunch more times, and that can increase the likelihood that you'll get kind of a random result. So the interaction model is another way to test this that is different from the subgroup and is sort of a more formal statistical test for something called effect modification. And in our analysis, we did not find any direct evidence of effect modification with this analysis. So the kind of main takeaways here are that the percentage of Black residents and social determinants of health are related to COVID-19 mortality at the county level, independent of the covariates. Also, the full social determinant model and subgroup analyses suggests that social determinants of health are associated specifically with racial disparities in COVID-19 mortality. And that two that sort of stood out were education and household internet access. And as Dr. Dalla Piazza mentioned, these are a direct place that there can be an intervention to reduce both COVID-19 disparities and the many health disparities that have been described previously and unfortunately are likely to continue with our current model of structural inequality. So a few of the limitations of our study include the fact that county data is heterogeneous, and we used our own county where our school is located as a good example. In Essex County, Newark's median income is $22,000, while Short Hills is $116,000. So, future studies that maybe are more targeted and looking at kind of neighborhood level or city level data might be able to make sort of different conclusions. We also have to recognize there are a lot of differences in COVID testing and reporting by county, and this could have affected our results as well. And as we just kind of discussed, the formal test of effect modification did not, it did not demonstrate a formal statistical significance. Lastly, we think although we tried, as we mentioned, to kind of hone in on 6 relevant social determinants of health, it's really almost impossible to fully capture that in one sort of analysis. And so there are other likely factors that should be considered. Okay, so with that, I'm going to turn it back over to Dr. Dalla Piazza, and thanks everybody for listening.
Thank you so much for that really wonderful review of our study. And as you had mentioned, these interactions are so incredibly complex that there's really a lot more that can be done to explore the connections between structural racism, social determinants of health, and health outcomes for sure. So we thought it would be helpful to kind of talk about some next steps and to offer some more definitions here. As mentioned in the introduction, I teach a course called Health Equity and Social Justice, where we really focus in on this definition of health equity. And health equity can be defined as that everyone has a fair and just opportunity to be as healthy as possible. And this is a definition put forth by the Robert Ward Johnson Foundation. And they suggest that this has to include social justice as a foundation, removing obstacles such as poverty, discrimination, and racism and their consequences. So really removing these obstacles and factors, structural factors that are put in place that influence health, these social factors. And then there's another really important definition that's really been emerging over the past few years, and that really has started to resonate with me on multiple levels, and that's the definition of anti-racism. This is the active process of identifying, challenging, and changing the values, structures, and behaviors that perpetuate structural racism or systemic racism. This is how racism affects the lived experiences of people of color and Indigenous people, how racism is systemic and has been part of many foundational aspects of society throughout history, particularly in the United States, how we often participate, often unknowingly, in racism and unintentionally, and how we begin to dismantle racist ideas and in particular racist health policy. So in looking at that initial figure that I had before, looking at the continuum of COVID racial disparities, there has been a lot done to try to alleviate these disparities throughout the country. And in fact, as we're preparing this talk, I got an email from a journalist, Edwin Rios from Mother Jones, who had questions about our study, who had come across it and wanted to kind of explore a little bit further local COVID level data to see if many of the interventions put in place in Flint, Michigan, where he was reporting from, had led to this closing of the gap. In fact, you saw in that initial COVID mortality disparity data that there was over time a closing of the gap of disparities for Black Americans, although they were still present, they weren't as such great magnitude. And some of the things that he talked about that they had done in Flint to close that gap was a concerted effort to eliminate testing barriers by really using mobile units and units that were easily available for walk-in testing, expanding community testing sites, imposing moratoriums on water shutoffs, and leveraging pre-existing networks of community groups. So really, engaging with activists and church leaders, public health officials, philanthropists, and business leaders to really all contribute to closing this gap. And then, we're really providing incentives to make equity a real priority in Flint, Michigan. And they had a structure to do this based on the advocacy that they already had in place for the lead water crisis that they had there a few years ago. And so here are just some examples of ways that we can, in thinking about how we're going to move forward, ways that we can narrow these disparity gaps. So making sure that we have equity in pay and paid sick leave, really increasing access and local access to mobile and walk-in testing, investment in housing and safe housing and worker protections, addressing social determinants, and investing in community-based care and preventive care. Really highlighting socioeconomic moratoriums like protections against turning off electricity and water, protections against evictions because of the socioeconomic impact that mitigation efforts have had. Really providing access to universal health care, and as I mentioned before, investment in underfunded public health systems. Community-informed protocols when you are developing protocols for clinical trials, whether it's focusing on treatment or prevention, and increasing promotional resources for promoting the vaccine, allowing the vaccine to be given in federally qualified health centers and other community sites such as churches or barbershops, and creating mobile clinics and walk-in clinics that don't require the use of technology in order to make an appointment and get your vaccine. And really underlying all of this, the most critical component is making sure that there are community-specific community engagement efforts that are part of this entire process. And what do I mean by that? Well, if you think about it, what is causing COVID disparities in Latinx populations, the structural barriers that are in place for them are very different than the structural barriers putting populations at risk who are in rural Appalachia and predominantly white. And those are different from the structural barriers that provide access to care and treatment and testing and vaccines for Black residents in the United States. And so each population has its own community context, its own local context, its own barriers to accessing treatment and care that need to be addressed. And you're not going to know what those needs and barriers are unless you engage with people in the community and make sure that each of these steps is community informed and community led. And that community engagement is really critical. So some key messages to kind of close it out. Just as a reminder, when we're talking about racial disparities, we are talking about racism. And our study demonstrated the associations between death rate of Black Americans and social determinants. But because of the limitations of our study, more study is needed in this area to determine the complex interactions between social determinants and structural racism, pandemic dynamics, public health measures, and the mitigation effects that they've had, and the disease risk that exists. And as I mentioned, community-informed anti-racist policies are needed to achieve greater health equity. And COVID-19 has really placed a magnifying glass on this urgent need. So thank you so much again for the invitation to come talk to you, and we're happy to field any questions and try to answer them if we can.
Thank you so much, Dr. Della Piazza and Matthew. That was wonderful and really hit everything I was hoping you would be addressing. So thank you so much. We do have a couple of questions, and just to give you one little piece of context, on these webinars, we have folks from private healthcare. Obviously, we have lots of predominantly public health folks, governmental public health, nonprofit organizations, et cetera. And many of our local health departments that I know are joining today have recently hired a position known as the Vulnerable Populations Outreach Coordinators. And this is funded through the State Department of Health, and which I'm sure comes from federal funding. And their goal really is to identify the vulnerable populations in their communities and do everything they can, right, to ensure that those individuals have access not to testing, to treatment, to vaccines, et cetera. And I wondered if there was anything in particular you might suggest to that group. And to follow up, we do also have a question here about specific recommendations for healthcare providers as well. Might you be able to suggest kind of really specific guidance for those two entities in particular? So, and maybe we can start with the first one, the group that are really intentionally trying to reach vulnerable populations.
Yeah, I guess I could speak to that a little bit. I in the bio you had mentioned that I have involvement in a number of HIV prevention and treatment protocols that we have, because we're a site for the AIDS Clinical Trials Group and the HIV Prevention Trials Network. And I think it's really exciting to hear that there are these positions created specifically for community engagement. A lot of the success that we've had in our research program related to community engagement has meant that that the people that we hire for that express purpose are part of the community themselves. And they are out in the community constantly, going to events. A lot of the vulnerable patient population that we really work with in our studies is the LGBTQ population. And so there's no LGBTQ event at Rutgers or Newark that our community outreach engagement folks are not involved in and not participating in and supporting and celebrating and promoting on social media. And the other thing is that they have also done a lot of focus groups and surveys, but focus groups in particular. And it's key that you make sure that there is budgeting in place to be able to compensate people for their time to communicate and to work in this arena. And those are some of the things that we've done to be successful when it comes to community engagement and outreach to vulnerable patient populations, and in this particular case, LGBTQ populations. The other thing we've done is made sure that our clinical care provides needs for that patient population. In fact, the story of how I became involved in providing gender-affirming hormone treatment is that our research program started to do a lot of outreach to transgender populations because we wanted to make sure that we were engaging with that population in our HIV prevention studies. And it became very clear from that engagement with the community that there was a huge unmet need with respect to hormone treatment. And so mirroring that, that clinical care and really transforming our practice to be able to meet that need went a long way then to kind of, to invest back in the community and meet that need and further engage with the transgender community and non-binary community in particular. So
that's great. Thank you. And it's at the crux of all of that is the critical importance of connecting with the community you're trying to serve, right? And hearing from the individuals you're trying to reach, because of course, nobody knows what they need more than they do, right? And
exactly.
Absolutely. Is there anything different you would say for healthcare professionals? And the question that came in, I'm not sure where this individual, if they're hospital-based or private, maybe it's a private healthcare entity. Is there anything that would be different that you would say to them?
I think, this is a lifelong learning process for healthcare professionals. And that's kind of a broad question, but I oftentimes, and Matthew can talk to this too, we talk about in our health equity and social justice course, a lot of times the first step is doing some very serious self-reflection and self-education. So over the past 5 years of doing this course, I have to say my thinking and my cognitive process on this has evolved really dramatically. And I've learned so much from doing this work. And so we often talk about our own unconscious biases, which are, of course, influenced by these structural factors and systemic factors. But I've also done a lot of independent reading. And if you look at my at my bedside, I read, every night for, 15 minutes or 20 minutes before I go to sleep. There's a stack of books, things like White Fragility, How to Be an Anti-Racist,
right.
Caste by Isabel Wilkerson, which I think is just, it's a phenomenal, remarkable book. Yeah. And so, we just had a talk with our fourth years on, so you want to talk about race, so, and that self-reflection of understanding where your bias lies and how you've been shaped by American society, what privileges you bring with you into every single interaction that you have, and then how you can begin to dismantle those racist ideas that you carry with you and your own biases. That is really the first step when you're really trying to move towards health equity and anti-racism. Matthew, I don't know if you had anything to add to that.
Yeah, no, I think it is a really great point. I guess one thing I've realized that I think healthcare personnel can think about too is, I think I've been hearing even before the pandemic and especially during the pandemic, many in healthcare almost universally acknowledge the need to investigate this issue further and sort of commit to it. But I think this is maybe the first project I've had the chance to work on where I feel like I got to kind of make that leap and start making a contribution to this big area of need. And I feel like healthcare providers from every discipline could get involved in kind of researching these issues and educating themselves and other people about it. And then that can start to make some changes. So I hope that in the future, I'm going into surgery and I hope to see kind of academic surgeons considering this as something that they should be researching further, not just leaving it to the domain of sort of public health researchers. I think we kind of all, regardless of our field, have a role to play in this issue.
That's great. Thank you for that addition, Matthew. I will ask one more question because we do have a couple of minutes, and this might be more of a macro level. The question was, or the comment and question about the issue of the lack of sick time and the lack of the ability for frontline workers like grocery store workers, or I would even say even home health aides, even industry workers, manufacturing employers often don't provide any sort of sick time. And so that maybe is more of a macro issue. And might you have any comments on that to share?
Yeah, no, I think this is a really important issue. I still remember in March of last year, in 2020, because I have a cohort of primary care patients that I follow, and I kept getting these panicked calls from patients wanting letters to excuse them for work because their bosses were, this is still March where people still weren't clear what was going on, but that fear level was rising. And of course, I have a lot of patients with HIV and we're very concerned about their health. And yet we're being said if they didn't come to work, they'd be fired. And so I started feverishly trying to write these letters, but I'm like, how do I even craft these letters? And will they actually be accepted by their human resources? And then even hearing our own human resources kind of floundering, not knowing what to do within the university, it was very kind of disconcerting. And I think that, I'm not, necessarily an expert related to law or policy, but I do know that there are a lot of policy efforts that they're trying to get a push forward, and minimum wage increase, like a federal minimum wage increase to $15 is one of those things that I think will offer a lot of protection to workers. But we have to include occupational health and sick leave protections for workers. Especially, we saw how workers with families were affected by this pandemic disproportionately, and forcing people to come to work or they feel almost compelled that they have to come to work when they're sick. That's a lot of what was happening, what was driving what was going on in March that led to us being completely overwhelmed and in April here in New Jersey. So I think that those are critical interventions that could really help in the future, not only with prevention of COVID going forward, but any future pandemic that comes our way, because there are bound to be future pandemics that come our way.